All right, so H's and T's. So these are the reversible causes. That's the important piece, is that you can reverse these things, and they're in a code situation, and you can identify, hey, we have a hyperkalemic patient here. Let's see if we can give some reversal, or let's see if we can fix the hyperkalemia. Or they were super hypoxic. Let's go ahead and get them oxygenated if we can, right? They're hypovolemic, we give fluids, right? So there's a little mnemonic here because it's kind of hard. You can think of H as H, you have hypoxia for lungs, you got hyperkalemic because of the kidneys. That can work, all right? Whereas your T's are, you got your T for thrombus, you got thrombus on both sides, like your PE, for instance. Toxins, they had too much, too many, like a fentanyl overdose. So we're trying to figure out the underlying cause that we can fix immediately, right? So over here on the right is again by H's and T's. On the left here is by system, like what is going on that we can think of. So cardiac-wise, what's happening cardiac-wise? They could have an MI. That could be why they're in VTAC, could be fib, right? And the arrhythmia could be even torsades or old scarring, right? An MI might not heal correctly, and it heals with scar tissue. So when the SNS goes down to send a signal, it hits scar tissue, and it can cause an arrhythmia to occur. By the same token, you can get bradyarrhythmias, but bradycardias can be due to a heart block, meds, again, an MI such as your RCA, hypoxia, hyperkalemia, and these are usually on the severe end. These are things, when you have bradycardias, it's usually due to a severe hypoxia or severe hypercapnia or severely low pH, because we know low pH, hypoxia, etc., they cause the SNS to fire off, and you should have tachycardias. This is basically when the medulla has shut down and it can no longer send the signal out for the SNS, right? So then the heart rate just goes down to its intrinsic rate of about 40 to 60 or so, right? And then aortic dissection, that can happen. It's cardiac-wise that we can be thinking about distantly, right? A chest X-ray can help afterwards or beforehand. If they got an X-ray, they can see if there's mediastinal widening, for instance. And then tamponade, right? Cardiac tamponade we mentioned already. And cor pulmonale, they have right-sided heart failure. They have a profound peripheral vasoconstriction, pulmonary vasoconstriction, and that could put a whole bunch of stress on the RV and cause the RV to fail. And they could have RV failure as well. So we're trying to look for these underlying things we can fix. All right, and then pulmonary-wise, so they have upper airway obstruction. That's easy. We're going there to see if we can take it out, right? Are they choking? Are they vomiting and they're aspirating? Do they have angioedema due to, as mentioned, our thrombolytics could cause angioedema, but also ACE inhibitors are very well known to cause upper airway swelling. And then respiratory arrest due to overdose on something, or they have severe asthma or COPD. They stop breathing because they tired out, right? And then tension pneumo. So COPD patients can get pneumothorax, right? So over here we got a tension pneumothorax is a worst case pneumothorax, right? But that can then lead to that can be due to a COPD patient. They can be spontaneous pneumothoraces. And it's happened here where someone's admitted with a pneumothorax and they go up on Levophed at 4 mics, 10 mics, 12 mics. They add vasopressin. They're going on. I can't figure it out. They're going to septic shock. It's like that might be the worst case scenario. Might be the pneumothorax that's getting worse and worse and worse and developing a tension pneumothorax, because the only difference between pneumothorax and tension pneumothorax is what? So it's low blood pressure, right? So it's that tension is compressing against the aorta, compressing against the heart. It's basically tamponading the heart, right? So that's something to think about when you have a pneumothorax. Is like, are they hypotensive? If they're hypotensive, is it like a sepsis process or something else, other kind of shock, or is it actually the pneumothorax that's causing it, right? And then toxins, right? They're overdosing on opiates. If that didn't cause respiratory arrest, they can have a low blood pressure that leads to a shock state and to an arrest. Hypoglycemic, so the metabolic problem you can kind of categorize as toxin metabolic, and that's where you get low glucose to the brain, and the brain needs glucose to function, right? And one of the functions is making the medulla work, and the medulla is what controls the heart rate and the breathing. So these are called neuroglycopenic symptoms, right? So penic means low, right? Leukopenia, neutropenia. So you got low glucose to your brain, you're going to start getting symptoms body-wide, right? You're going to start shutting down, they're going to start getting comatose, lethargic, and then they can even lead to an arrest. All right, and then lights. So we got our hyperkalemia, hypokalemia, low mag leads to torsades. We know about torsades, right? And hypokalemia could be just as bad as hyperkalemia. So we had a patient that had a K of I think it was like 3.1. the day before at 6 a.m. and the nurse gave Lasix, and the nurse gave Lasix the next day at 5:30, and the patient arrested, right? Because there was no potassium to assess, right? So when you fix hypokalemia, you can give IV potassium. It made the pharmacist that day really clench. What are you guys doing? You have IV potassium? It's like, they're already dead. I don't know what to tell you, right? So that was something that we could, as long as you have everybody on board, that's something that can be done if you know that is the reason. Hypokalemia is a legitimate reason for a cardiac arrest. And by the same token, hyperkalemia is. And what do we give for hyperkalemia if someone's arresting? Calcium what? You combined them. Calcium chloride, right? So versus calcium gluconate, right? So not calcium chlorinate, right? So yeah, so calcium gluconate is slower. It works about 30 minutes to an hour, whereas calcium chloride works right now, right? And you can think of CC, calcium chloride, is in the in the crash cart, right? That's the one you want to grab if someone's hyperkalemic. And that's not going to lower their potassium. All it's going to do is stabilize the membrane for about 20 minutes, right? So we can get ROSC, hopefully. And then we have to give other agents to help lower the potassium, such as insulin and dextrose, right? Bicarb that's what you say. Do not push bicarb, because we don't give bicarb is going to worsen someone's hyperkalemia, especially if they're not breathing. All right, and other things. So you got shock states, right? All the shocks, and we have a whole lecture dedicated to shocks. We talk about all the different shock states and how they're fixed and such. But those can legitimately lead to low blood pressure, low flow to the brain, low flow to the medulla, low flow to the heart. All these things are going to start causing deterioration and decompensation. And intracranial hemorrhage, an ICH, right? That's going to obviously compress, again, the medulla, which controls your heart rate and breathing, right? And then hypothermia. So they're too cold, right? Everything works at an optimal pH, and everything works at an optimal temperature. So whether you're hyperthermic or hypothermic, things can't work good, things can't conduct good, protein channels can't open and close, you can't conduct electricity, right? Whether it be in the brain or in the heart. All right, so ROSC. Okay, so you have, what is ROSC? That's the return of spontaneous circulation. So how do you know you have ROSC? How do you know it's time to stop doing CPR? All right, that is when you have an end-tidal CO2 that bumps up by 14 points or so, right? You have end-tidal greater than 30, for sure, you have ROSC. You could stop CPR at that point, right? So you can stop CPR when you have end-tidal CO2 jump up. If you have an A line in place, you get a diastolic blood pressure that cranks up. That's going to be a valid way to assess that they've achieved ROSC, right? So an A line or end-tidal CO2, those things are valid ways to say that, oh yeah, they got ROSC now, right? Because it's very busy during a code. Everyone's trying to feel for a pulse or here and there. I don't feel for a pulse, but you see an end-tidal 30, they have a pulse. It's just we have to, maybe get an A line if we don't already have one, so we can get a good tracing of what's going on. All right, you get a measurable BP without compressions. Oftentimes you'll see people hit the NIBP during compressions. That's just showing how good heroes compressions are, right? It's like, okay, what's the patient's pressure, right? So basically, once you get ROSC, you want to hit an NIBP right away to see what are they perfusing right now, because oftentimes they have a sick heart, right? Because you were just compressing on it, and you might have to start pressors right away. So we want to make sure we get a blood pressure right after ROSC, or they all got to feel a pulse. The next thing is get a blood pressure, see where we're at. Okay, because you won't have ROSC for long, because it might just be all the epinephrine or whatever, just kind of it will dissipate over time. All right, when you get ROSC though, it's not like Hollywood. It's like, oh, you're all better now, let's go to the movies, right? It's going to be, it's not equal to neuro intact survival once you have ROSC, because ROSC could be 30 minutes, ROSC could be 1 minute. 1 minute obviously has much better outcomes, right? But our goal with this is just to make sure that we have avoid secondary injury as much as possible, right? So cardiac respiratory wise, we're going to optimize, and neuro-wise, we're going to optimize, and we're going to avoid any kind of secondary injury from different elements of each system, but also avoid the complication of CPR itself, because CPR is a traumatic, violent action or intervention that we do, and it can have its own complications, such as like a pneumothorax or bleeding, as we'll point out coming up. Okay, so how do you know? We look at the H's and T's. We're figuring out what the reason is, right? Why did they arrest? So H's and T's you can assume, right? You can't really get a good diagnostic test, so now it's time to do the diagnostic tests, right? We're trying to figure out if it's a cardiac reason, right? We can revascularize. Do they have an MI on our hands? Do we have 12 lead? We get a 12 lead and see, do they have like an anterior wall MI or a posterior wall MI? So that's why we are looking at these things, right? Do they have a STEMI? If they have a STEMI, we're going to call cardiology and let them know, hey, we've got ST elevation here. And they'll say, did you just do compressions? Repeat the EKG, because that's a valid point. So usually you do it, 8 minutes after you get ROSC. So it's like, that's usually how long it takes anyways. But either way, you get a 12 lead done and it shows a STEMI, they're going to say, why aren't you going to cath lab? They're looking at this red box I pointed out before, right? If their age is greater than 85, their pH is really bad, it was more than 30 minutes, it was unwitnessed, it wouldn't be unwitnessed in the hospital. But these are all reasons why you would, why they wouldn't take them to cath lab right now, right? They might have you optimize them and see if they, they do get in neuro intact survival, then they may take them to cath lab, okay? And then what else? So those are unfavorable outcomes. If it's in STEMI, we're not going to really do anything just yet. We're going to trend troponins, for instance, see if they keep going up. Then yeah, we might take them to cath lab later. All right, and then perfusion to avoid any kind of secondary injury or things we're going to monitor is to make sure the map is adequate, right? Make sure the map is good to the brain, to the heart, to the kidneys, and avoid any kind of secondary injury to those organs, right? And when you have inadequate blood flow to your brain for 20 minutes, your brain gets upset, right? It gets hypoxic and it starts getting edematous. We'll discuss how and why in neuro, but it gets edematous, and that's going to do what to the pressure in the brain? It's going to swell within an already enclosed cranium, and it's going to cause a rise in the pressure in the brain, right? And that's ICP. So perfusion of the brain is dependent on what I deliver, right, with MAP, minus what is pushing down the ICP. So we actually want a MAP about 75. That's better, because we can assume they probably have an ICP of at least 10, right? So we want to make sure that we have a good support to the brain. And respiratory-wise, what things we're going to do respiratory-wise, we maintain the end-tidal CO2, so we don't want that to start tanking down to less than 20, and that's another arrest, right? We want to make sure we are eyeballing it before it gets worse. Gets SATs 92-94% because they had an insult to their brain. Or they probably had an insult to their heart too, would you say, right? You do CPR, right? So that's so you want to make sure you have good 92-94% SATs. Don't overventilate, right? So tidal volume 6 to 8 per kilos. Respiratory rate not too fast, right? End-tidal CO2 will help guide us. We don't want the CO2 to get too high and hypercapnic. That's not good for the brain. And the flip side, hypocapnia is not good for the brain. So we'll talk about that more, especially in neuro. Okay. And then neuro-wise, what are we going to do to protect the brain? We do TTM, which is targeted temperature management. It used to be called therapeutic hypothermia, but that's an oxymoron now. We found out in 2021 that it was actually causing more harm than good. So we don't do therapeutic hypothermia, we do therapeutic normothermia, or targeted temperature. We choose a temperature and we target it. So you don't go any higher than 37.5, let's say. Okay? And you're, again, avoiding secondary injury. So the hope, if you want them to get hypoglycemic, that's going to be another insult to the brain, right? So you maintain euglycemia. Eu means normal, right? So euglycemia, eutension, eucapnia, euoxia, euvolemia, euthermia, everything, right? So that's the whole point, is everything needs to be normal. And little asterisks, like MAP 75, then a little bit higher, right? So greater than 75 for this guy. But eucapnia, definitely you're not getting hypercapnic and definitely not too hypocapnic. And then as far as the temperature, we definitely know when the temperature goes up, metabolic processes goes up and more oxygen demand, so we want to keep that under control as well. Okay, so we're doing all kinds of diagnostic tests to make sure that we are keeping all our patients within these parameters, right? So that's the idea. So cardiac-wise, we have different tests we can do. Pulmonary, renal-wise, we're going to monitor, make sure the K is good after an arrest, make sure the electrolytes are okay, make sure, and we can expect some insult to the body, right? We can expect an insult to the brain, and that can cause them to lose the ability to do, purposeful movement, for instance. And we can have, damage to the kidneys, pre-renal failure. We can have damage to the lung, to the liver. We call it shock liver, when they have a low blood pressure to the liver for a certain period of time. So these are all things that we can eyeball and track and trend and make sure we are optimizing it post-arrest. Okay. So goals cardiac-wise, right? Do we need cath lab, like we mentioned, right? If they have arrhythmias, do we need to give antiarrhythmics? If they have VTAC, what rhythm are you going to give? Or not rhythm, if they have the VTAC rhythm, what medication will you give? Amio, right? Amio is usually a good go-to. And usually, what if they had torsades? That's a ventricular arrhythmia. Would you give amio right away, or you pump the brakes just a second? You would then, you pump the brakes and say, well, what's the QTC, right? So the QTC being prolonged, amio is gonna also prolong it, right? So we have other options like lidocaine. Lidocaine could be an option if someone has prolonged QTs. But yes, you mentioned magnesium if they have torsades. That's something else to check as well. And basically you're getting a rainbow of labs. You're getting all the labs to see what will possibly happen to this patient. Why did they code, right? So an EKG echo are on the table, right? And then if they have any cause of VTAC, VFib arrest, again, that's probably, we got to figure out, do they need to go to cath lab or not? But also, amio may be started in the meantime with that VTAC, VFib as their initial rhythm. And then afterwards, of course, they'll be on DAP therapy. But then what else? So post-arrest, when someone has an arrest to the body, is that an inflammatory insult? Is that an insult to the body? It's a big insult. So the body's going to go crazy and it's going to start throwing off all kinds of cytokines, whether it be due to hypoxia or the LV not pumping blood. All these cytokines are going to start causing all kinds of damage to the body, all right? So it's called a systemic inflammatory response, right? Or syndrome of a systemic inflammatory response, SIRS attack, right? So that can cause more harm than good. So like during COVID, we got a little COVID virus, then all of a sudden our body responded haywire, right? And you get this surge response, which causes all this secondary injury, the ARDS, the kidney failure, and it causes a shock state as well. So these patients are high risk for SIRS, right? Was it an infection, which is kind of the most common reason for a surge response? Well, no, it was actual cardiac arrest that did it. So we got to make sure we can stop that, and we can stop that with steroids, right? So steroids are going to calm down that cytokine storm. So that's something that can be considered post-arrest as well. But in the meantime, you don't want a secondary insult with low blood pressure, so we're going to make sure the blood pressure is good. And what kind of map do we say? It's a map of 75, right? We expect the ICP to be elevated, especially if they had, they're down for a long period of time. Okay? So again, our steroids are like, shh, just calm it down, right? Calm it down, it's okay, right? And then you can see up here is VTAC arrest. He's just VTACing away, right? It's barely moving, right? But the ventricles are fibrillating. And as we mentioned with occlusive MIs, there's 10 different variants that you had to slosh through when I told you all of them, right? Scarbosa and Dewellens and all these different types of different episodes that can happen, right? And of course our posterior STEMIs as well. And then post-CPR. So CPR is not without its complications. So you can see that it's mechanical trauma to the body, so it can cause, puncture of the lung, broken ribs. If they have central lines in place, they get dislodged, right? So we want to make sure we're getting an X-ray afterwards for the word, it's an eyeball. Do they got a hemothorax? Do they have a pneumothorax? What's happening there, right? And if your patient's not getting better in like 2 days or still shocky, sometimes getting what's called a pan scan. You're going to scan the whole body from head to toe, or head to pelvis at least, right? And you're going to see, are they bleeding somewhere? Do they have a splenic laceration? Do they have a liver laceration? So you're trying to do CBCs and H&Hs for that reason. Okay, so you can see the difference here between VFib and asystole, sort of. So you can see the VFib on the left there, it's just not moving any blood. And asystole was not moving at all. And getting those little echoes during the arrest and also post-arrest is really helpful to figure out what the H's and T's are. We can find a tamponade of some sort, or we can find that they have pericarditis with a tamponade. Okay, so pulmonary goals. So as we said, everything needs to be normal. So normal CO2, normal PO2, and be alert that they can aspirate. Because when they have a cardiac arrest, are they swallowing adequately? For that 20 minutes, 30 minutes, 10 minutes, 5 minutes? They're not, all right? So they're very, very high risk for aspirating, right? You lost oxygen to your heart. Do you think your mucociliary transport system and your lungs are operating at full capacity right now? No, they're easily able to aspirate. So again, x-rays can help. You're not going to see x-ray changes for about 24 hours, 40 hours right away. But if it's a huge aspirate, you might see it right there on x-ray post-arrest, right? And it should be low threshold to start antibiotics, especially if they have a high FiO2 requirement. Sometimes you get reported they're cardiac arrest and they're 100% FiO2. So why that 100%? Or did they have a lung process? No. Well, that might be aspiration that caused it, right? So we want to make sure we're on the right stuff. Okay. And then what else? So establish end-tidal CO2. That's going to make sure your CO2 is in the right level, right? 35 to 45. And make sure that we have a you don't want to make sure it gets too low, because actually hypocapnia is worse than hypercapnia for the brain. The brain will vasoconstrict to when you're hypocapnic, like less than 35, 30, 28. But once you start getting less than 28, it vasoconstricts completely, and now you have no flow to the brain. So I want to make sure that we are not getting a state where we are causing too much hypocapnia. And of course, hypercapnia is going to vasodilate, and a brain that's already swollen, that's not good either. But 35 to 45, right? Everything is U, all right? Eucapnia, all right? And normoxia or euoxia, you want to make sure your oxygen level is adequate, right? Titrate FiO2 just to a target of 92, 94%. That's where we want it, right? They had, when we said 92, 94% is only for 2 patient populations, for neuro populations and heart populations, right? So that fits that deal. Here's an example of that cytokine storm that's going crazy. There's all kinds of interleukins, 2 necrosis factors, and cytokines and complement systems and histamine, all kinds of things are firing off. And what do steroids do? They stop all that stuff. So that's the idea behind giving steroids. It's anti-inflammatory. Are they a risk for infection? A little bit, but the benefits outweigh the risks, right? And aspiration pneumonia, again, we're giving antibiotics for this. There's an example of the brain regulation with CO2. We'll talk about this more when we talk about neuro and how your brain auto-regulates its flow of blood to itself. It will be able to say, hey, I need more blood flow. I'm going to squeeze down a little bit, just like a hose, and we're going to increase the pressure to my brain, right? And then same thing when I have too high of a blood pressure. It's going to start, whoa, that's way too much, right? And curiously, when you have a brain injury or brain insult, it loses that ability. So we have to support that. We have to make sure the MAP is more than 75. Okay, so TTM, as we mentioned, TTM is targeted temperature management. You're doing targeted normothermia, the 37.5, for instance. And we're checking temperatures every hour in these patients. And there's a whole TTM lecture where we talk about TTM and how to manage it and how to manage the machine, right? Because it's something that you want to make sure they're not getting secondary injury. That's the whole purpose of post-cardiac arrest care, is to avoid secondary injury. Okay, so TTM, again, is going to be, you're looking to see, are they following commands or not, right? Are they purposeful? All right, are they able to, give me a purposeful movement? And oftentimes you're going to hear nurses or physicians or providers say, squeeze my hand. That's not purposeful, right? A baby can squeeze my hand. So I want to make sure they are doing purposeful movement. So like, give me a thumbs up, right? That is following verbal commands, right? Like show me a finger, and they show you the middle finger. Perfect, right? Keep doing that every hour when I assess you, because that's what I'm going to keep asking you silly questions, right? Because this lack of flow to the brain is going to cause secondary brain injury. And we're going to avoid secondary brain injury by making sure the brain doesn't get febrile and make sure the glucose is under control. And again, this targeted temperature management is controlling that temperature, making sure the temperature is good. And again, it used to be therapeutic hypothermia. They used to, neurologists and neurosurgeons, they went overboard. They're like, make sure the sodium is 160. I want that osmo to be ridiculous, right? They're like, I know how to stop metabolic processes, make them super cold. All right, let's get a phenobarb coma for 7 days. And they're like, there is way too overboard, right? So they realized there's a lot of bad outcomes that happened with doing those therapies, including TTM, which is the most recent thing. In 2021, we don't do it anymore because it caused way too much hypotension and way too many arrhythmias, which caused death in of itself, right? Oftentimes also, they were too cold, and some people didn't reboot as well as another person, right? A 35-year-old doesn't reboot from this cold dip that we did before. We dipped them down for 3 days and warmed them back up, and we then assessed them and say, hey, are you alive? Give me a thumbs up, right? And then they said, like a 35-year-old might reboot real fast compared to a 75-year-old. And then they had a family meeting with a family for a 75-year-old and said, you know what? They're not waking up, they're not following commands. Let's go ahead and do comfort care and pull the plug. Oops. Right, so that caused a lot of bad outcomes, right? Not bad outcomes, but early withdrawal of care when they could have had a good outcome, right? So that's a big oopsie. All right, so yeah, before TTM can begin though, you want to make sure that you're assessing that do they need it, right? You don't need TTM if they follow commands, right? So this is just your kind of primers to TTM. And then sometimes you want to get a CT scan because if they have a bleed, you want to make sure you're fixing the bleed because we used to cool them down and that would make them bleed more. But again, right now CT scan is not the most important thing to do. And of course, how do we assess if someone is alert and following commands? you don't give them sedation or paralytics for that matter, right? Oftentimes, the ER is great and they'll intubate, if someone has cardiac arrest and everything, and they're like, I know what to do, propofol, fentanyl, right? And it's like, no, don't start any sedation. I need to make an exam of this patient and see if they were following commands or not, right? That's our ACLS guidelines. So when you learn ACLS, you learn TTM. And on the guidelines, it says following commands, question mark. If they are, then you don't do TTM. If they don't follow commands, you need to then do TTM therapy or avoid secondary injury, basically. So they follow commands on a GCS of 6 on the motor, no TTM. Everything else is TTM. It's like, oh, they made an effort, they're moving around. That doesn't count. They have to follow commands. Okay. And what else? So sometimes there are contraindications to TTM and criteria, but here at Palmdale we cool everybody, right? Unless it was like an obvious comfort care patient. But other than that, everybody gets not cooled. That's a misspoke. We used to always cool everybody. We always make sure people don't get too cold and don't get too warm, or use targeted temperature management. All right. So what is cardiac arrest survival? Every minute you don't get, adequate care, your survival drops by 10%, right? So doing early CPR and informing the public helps improve these numbers, right? Out of hospital cardiac arrest, our goal is, to save more lives. But that's the point, is early CPR is going to restore perfusion to not only the heart, but hopefully restore perfusion to the brain, right? So out of hospital, just as a ballpark, it's about 10% survival. So if someone has a cardiac arrest at Walmart, it's only 1 in 10 chance they were going to make it out of the hospital afterwards. In the hospital, it's not much better. You'd think it'd be a lot better because we're monitoring them. It's only about 20%. All right. And again, survival does not mean intact neuro survival, right? They were, again, an engineer or NASA person or work at Lockheed or able to do complex math, and now does that mean they're going to do that afterwards? Not necessarily. If they have no deficits, we use what's called a cerebral performance score, or CPC. And that or category score. So cerebral performance, are they able to have no deficits? Are they back to normal, no problems? That's a 1, perfect. If they leave the hospital dead, that's a 5, right? But if they have, some dysfunction in between, we track that, right? And they track all these cardiac arrests across the country and in Europe and such, and they are able to know based on how many minutes their arrest was, what kind of arrest it was, what the likelihood of survival is, right? There's this score right here, just kind of give you an idea of what the mortality is. So you got 100% mortality when we start getting scores of 7, 8, or 9. So you got someone that has greater than 80 years old, you're already 3 points in, right? You have someone that has a low pH, that's 1 point. Someone gave epinephrine. Well, you give epinephrine all the time. That's already 5 points right there, 6 points, right? They, is unwitnessed. That's going to add it up. Reactivity of pupils. All these things are easily get you up to a 7, 8, or 9 and really high mortality. Okay, so that's the idea to post for initial arrest, that are they going to have a good outcome or not. This is used with what's called neuroprognostication. What are they doing right now at discharge versus 3 days versus 5 days? They're able to assess what's happening, right? They can assess earlier if there's like active seizure activity. That's not good at all. But at 72 hours or 4 days, they're not really recovering, right? That's telling for what the kind of recovery they might get. But they usually assess this on discharge. They'll assess it at 6 months and to a year, and they can track these things out to see what kind of interventions we can do. So they'll say, hey, let's see, did they give epinephrine early? And they found out if you give epinephrine early, these patients survive better. They had better neuro-intact outcomes, and that's kind of the goal. Yeah, they survived, but did they actually survive? So like giving amiodarone after the 3rd shock, does it actually improve survival? Yes, but does it actually improve neuro-intact survival? No. So that's how these algorithms will change over time.